At 2 in the morning, you open your eyes, check the clock, and face another dark walk to the bathroom. Then it happens again. Meet Helen, a fictional example created only to show this process, not a real patient or promised result. She wonders whether her bladder is the whole problem. The better starting point is careful observation. Today you will learn to record the pattern and understand one possible daytime connection. You will build a cautious routine, make each trip safer, and prepare a focused conversation with your clinician. Nocturia means waking during your main sleep period to pass urine, then intending to return to sleep afterward. If you urinate after deciding to begin your morning, that final visit does not count as nocturia. The symptom can have several contributors. The bladder may store less, the kidneys may produce more urine at night, or another sleep problem may wake you first. Medicines and medical conditions can also influence the pattern. This video cannot identify your personal cause with certainty, and it does not replace an assessment. We will move through 5 practical stages. First comes a 3-day diary. Then we will consider leg swelling as one possible contributor. Next come cautious habits, fall protection, and a more useful clinician review. Your diary determines which later ideas deserve attention. Begin with 3 ordinary days and nights. Use paper or a phone note, a clock, your medication list, and a measuring container when measuring is safe. If measuring at night feels unsafe, record the visit without measuring and protect yourself first. Record bedtime, your estimated sleep time, every awakening, and your final morning wake time. Note whether bladder pressure woke you or whether you were already awake for another reason. For every bathroom visit, write the time, measured amount when possible, and any urgency. Record each drink with its time and approximate amount. Include caffeine and alcohol. During the day, note ankle swelling, deeper sock marks, whether one or both legs look different, long sitting periods, and activity. Also record when you take prescribed medicines without changing them. Keep your usual routine during these observation days unless safety or existing medical advice requires a change. A baseline becomes harder to understand when several habits change together. Afterward, look for broad patterns, not diagnoses. Repeated small amounts may differ from larger nighttime volumes. Sometimes another disturbance starts the awakening, followed by a convenient bathroom trip. Bring every pattern to a clinician. The diary is a conversation tool, not a verdict, and it is more informative than guessing from one difficult night. If a 3-day record feels more useful than guessing, give this video a like now. That action can help another viewer find a clearer starting point. It does not change anyone's health, but it can spread careful, safer information. Now look at one daytime clue that may appear in your record. Near evening, some people notice puffy ankles or deeper marks from their socks. While you are upright, gravity can contribute to fluid collecting within tissues of the lower legs. After you lie down, some of that fluid may return to the circulation. The kidneys may then filter more fluid and produce more urine during the night. This fluid does not travel directly from your legs into your bladder. It returns through the circulation before the kidneys process it. This mechanism can contribute to nocturia in some people, but it is not a universal explanation. One observational study involving 34 older men found an association between leg fluid accumulation and nighttime urine volume. An association does not prove that leg fluid caused every bathroom trip. A separate small study measured short-term changes in leg fluid with posture and leg raising. It helped researchers explore the mechanism, but it did not prove a guaranteed treatment result. Controlled trials are needed before estimating how often this pathway matters clinically. Your diary provides context. Evening swelling beside larger nighttime volumes may deserve discussion. Many small voids could reflect a different storage pattern. You might wake because of pain, noise, breathing trouble, or another sleep disruption, then decide to urinate. Marked thirst with large volumes may need metabolic review. Medicine timing may also matter. Helen, our fictional example, notices sock marks and records them without deciding what they mean. That is the right approach. A clue can guide a question, but it cannot diagnose the cause. The distinction matters because the safest routine depends on the pattern. Without it, a viewer might restrict fluids unnecessarily, overlook a sleep issue, or try a leg strategy that does not fit. Treat swelling as information, not a secret answer. If your ankles never swell, this mechanism may be irrelevant. If they do swell, the cause of that swelling still needs context. The next safety check must come before elevation, compression, massage, or new exercise. New swelling, pain, warmth, or redness in only one leg needs prompt medical assessment because a blood clot is possible. Do not massage, compress, or exercise that leg before assessment. Sudden shortness of breath, chest pain, coughing blood, fainting, or severe breathing difficulty requires emergency help. New or worsening swelling in both legs can also need prompt review. This is especially important with breathlessness, difficulty breathing while lying flat, or rapid weight gain. Severe breathing difficulty or chest pain is an emergency. Ordinary sock marks do not prove a clot or heart problem, so stay calm and notice the full pattern. However, no home routine should delay care for these warning signs. If you are uncertain about a new change, contact a clinician. Keep emergency numbers accessible and tell a trusted person if you need help reaching urgent care safely tonight. Safety comes before testing an idea from any video. Which format would be easiest? Paper, a phone note, or a printable chart? Leave a comment about the format only. Please keep symptoms, measurements, diagnoses, and medication details private and discuss those with your clinician. After the baseline diary, begin with the lowest complexity habits. Drink adequately during the day because deliberate dehydration is not the goal. Then avoid large or unnecessary drinks during roughly the last 2 hours before sleep, unless your clinician gave different instructions. This is not a complete evening fluid ban. Heat, illness, exercise, thirst, kidney conditions, heart conditions, and prescribed fluid plans can change what is appropriate. Use the bathroom calmly before bed, without repeated straining or forced visits. Review your diary for late caffeine or alcohol. Either may disturb sleep or urinary patterns for some people, but one drink does not create a predictable number of episodes. Consider reducing one late item and observe several nights. Do not change several habits together, because you will not know which change mattered. Compare the follow-up pattern with your original 3 days. Your baseline helps prevent overreacting to normal nightly variation. A single better night is encouraging, but it does not prove a cure. A difficult night does not prove failure either. Sleep, weather, activity, meals, stress, and illness can vary. Ask your clinician how long to observe before judging a change. Most importantly, protect adequate hydration and follow individualized advice. The next part only applies when dependent swelling is genuinely present and a clinician considers a leg-focused approach appropriate. If swelling is part of your pattern, ask whether supported leg elevation during the day or early evening is appropriate for you. Guidance sometimes includes raising swollen legs, but evidence does not justify a fixed duration or promised reduction in nighttime visits. Choose a stable, comfortable position. Support the legs securely instead of balancing them on an unstable stack. Do not use elevation as a substitute for evaluating new swelling. Stop and seek advice if you develop pain, numbness, color change, dizziness, breathlessness, or worsening symptoms. Appropriate daytime movement may also support circulation and general health. That could mean safe walking or mobility approved for your abilities. Gentle ankle movement can be described as mobility, but it has not been proven to empty fluid or cure nocturia alone. One randomized program combined exercise, fluid management, sleep habits, pelvic floor work, and edema management. Because the program bundled several measures, its results cannot prove that one exercise created the benefit. Adapt every movement to balance limits, joint pain, neuropathy, vascular disease, heart conditions, and mobility aids. Use a stable support when your clinician or therapist recommends one. Never exercise through concerning pain or new one-sided swelling. Once the baseline is complete, select one manageable change. Record what you did, when you did it, and what happened that night. Repeat long enough to see a pattern your clinician can interpret. Do not declare success after one quiet night, and do not intensify the routine because a social media story sounded convincing. Subscribe if you value health guidance that separates evidence, uncertainty, and safety. This channel is educational, not a clinic, and it cannot replace your clinician. Subscribing helps you find future guides built with careful limits. Compression stockings require more caution. Daytime compression may be an option to discuss when leg swelling appears in the pattern, but the nocturia evidence remains preliminary. In one small study, 31 participants were analyzed after using compression stockings. The study reported about half a fewer nighttime visit and about 0.8 additional hours of undisturbed sleep. It did not find a significant change in nighttime urine volume or the nocturnal polyuria index. Some participants withdrew because of pain or refused to continue. No comparison group means the result cannot establish a reliable effect for everyone. Selection and fit matter. Circulation should be assessed when peripheral arterial disease is possible. Do not start compression simply because your socks leave marks. Ask a clinician whether it fits your health history, skin condition, circulation, swelling pattern, and mobility. Stop and seek advice for pain, numbness, unusual color change, skin injury, or worsening symptoms. Sodium is another area where context matters. Research suggests that reducing sodium may help some people whose intake is high. It is not universal. A clinician or dietitian can help interpret your intake, blood pressure, medicines, kidney health, heart health, and nutritional needs. Never add salt at bedtime to control blood sugar or nighttime urination. Avoid abrupt dietary changes based on online claims. After any approved change, compare several follow-up nights with your baseline. Track possible benefit and unwanted effects. Use words like may and possible when describing the result. No stocking, food rule, supplement, or routine deserves a cure label or a success percentage for everyone. Now write a complete list of prescriptions, non-prescription medicines, and supplements, including the time you take each one. Bring that list beside your diary. Medicine choice and timing can affect nighttime urination, but the prescriber owns every change. A small trial in older men studied an afternoon dose of furosemide and found a modest average difference. That research is not a dosing instruction and does not show that the approach is right for you. Desmopressin is another clinician-managed option that requires safety screening and monitoring. Never start, stop, split, double, skip, or move a diuretic, desmopressin, blood pressure medicine, or other prescription because of this video. Do not copy a study schedule. Ask your prescriber whether timing, side effects, interactions, or an underlying condition deserves review. A pharmacist can help organize the list, but prescribing decisions remain individualized. Some supplements can interact with prescriptions or be unsuitable for conditions. Include names and doses in the list. Your useful action is documentation, followed by a qualified conversation, not self-medication. Share this video now with someone who makes regular nighttime bathroom trips. Sharing does not prevent a fall or treat nocturia. It simply offers a careful starting point and clear reasons to seek individual advice. Frequent nighttime trips matter even before their cause is clear, because walking while sleepy can expose fall risks. One prospective study followed older adults and found an association between 3 or more nightly voids and falls. The adjusted relative risk was 1.28. That association does not prove that nocturia caused each fall. It also does not prove that treating nocturia prevents falls. Use established protections now. Place nightlights along the entire route from bed to bathroom. Clear cords, loose rugs, clutter, and anything that narrows the path. Turn on the bathroom light. Use installed grab bars, not towel rails or furniture. Keep glasses and a prescribed mobility aid within easy reach. Choose supportive footwear instead of loose slippers or socks that slide. When you wake, sit briefly before standing. Rise slowly, pause for balance, and avoid rushing even when urgency feels strong. Keep a phone, call button, or help plan accessible when appropriate. If the bathroom route remains unsafe, discuss a stable bedside commode or suitable urinal. Placement, transfers, hygiene, caregiver needs, and your mobility all matter. Ask for a review of medicines, vision, strength, balance, and persistent dizziness. Strength and balance support may be useful when recommended for you. Never improvise by holding a rolling chair or unstable surface. Check the route in daylight, then check it again with the nighttime lighting you will actually use. These steps can reduce hazards, but no setup guarantees that a fall will never happen. The next safety check covers symptoms that need faster medical attention than a routine appointment. Get emergency care if you suddenly cannot urinate and have severe lower abdominal pain or swelling. Do not wait for a home routine or another diary entry. Visible pink, red, or cola-colored urine or blood clots needs prompt medical assessment even without pain. Heavy bleeding, blocked urine flow, weakness, or fainting can require emergency care. Burning urination, cloudy or strong-smelling urine, lower abdominal discomfort, fever, chills, nausea, vomiting, or back or side pain can signal infection. Seek medical advice. Severe illness, confusion, or rapid worsening is urgent. Frequent urination with intense thirst, unexplained weight loss, fatigue, or blurred vision needs medical evaluation. Diabetes is one possibility, but symptoms alone do not establish that diagnosis. Do not try to correct suspected blood sugar changes with salt, supplements, or fluid restriction. Contact a clinician for testing and guidance. Use the clearest level of action. Sudden, severe symptoms need emergency help. New concerning symptoms need prompt assessment. A persistent pattern without urgent signs deserves a scheduled review. Your diary supports that review, but it must never delay care. If local emergency guidance differs, follow your local services and existing medical plan. Save this video, complete your 3-day diary, and bring the record with your medication list to your appointment. Saving it cannot promise symptom relief, but those records can support a focused and productive discussion. At the appointment, report how many nights you recorded, each nighttime amount, and whether bladder pressure or another awakening came first. Mention daytime swelling, drinks, medicine timing, sleep symptoms, dizziness, falls, and every warning sign. Ask whether the pattern suggests increased nighttime urine production, reduced bladder storage, disrupted sleep, medicine effects, edema, or another condition. Ask whether testing or referral is appropriate. Then ask which single routine change is safest to try first and how to judge it. Bring questions in writing and ask the clinician to explain which findings matter for your situation. Arrange follow-up if the pattern changes. The order matters. Measure before guessing. Treat leg fluid as one possibility, not the answer. Choose individualized, low-risk steps. Make the nighttime route safer now. Let a clinician interpret the pattern and manage prescriptions. The realistic goal is clearer information and safer decisions, not a guaranteed uninterrupted night.